So I think we will get started now, so as not to lose any time for discussion and question and answers at the end of the lecture today. So anyway, welcome to the Cambridge Centre for Health Services Research annual lecture. And I'm John Sussex, ought to say that. I'm one of the co-directors of the centre and a senior health services researcher at RAN Europe. My fellow co-director is Professor Steve Morris, the RAN Professor of Health Services Research at the University of Cambridge. And you'll be hearing a bit later from Steve when we get to the Q&A and discussion part of the lecture. So first, a little bit of housekeeping, not much. Just to say, first of all, many of you will have noticed that we are recording the lecture. So, and we will be recording the questions and answers. So if you'd rather not be recorded, I'm afraid you will have to leave because we are going to be recording. Hopefully that's not a problem. Just also to say that the Q&A session, which will follow Mike's lecture and a response to Mike's lecture by Professor Rebecca Fitzgerald, the Q&A will be through the Q&A function at the bottom of the Zoom screen. So we're not using chat for the questions, we're only using the Q&A button. And please do use it freely. On those kinds of things, just to say, if you'd like to tweet, then please do. And the hashtag is survivalgap, all written as one word, survivalgap. Because Mike's title for his talk is Closing the Survival Gap, the Importance of Screening and Early Diagnosis in Improving Cancer Survival in England. And as you'll have spotted by now, we have Professor Sir Mike Richards, who's going to deliver that lecture. And Steve and I are absolutely delighted that we're able to persuade Mike to do this. So thank you very much, Mike. Greatly looking forward to it. And he will be followed by with some remarks by Cambridge's very own Professor Rebecca Fitzgerald. So I'll say a little bit more about Mike and Rebecca now, and then get to the interesting bit, the actual the talking. So I would like to introduce Mike briefly, though I know that a lot of people listening now will know a lot about Mike and his career. He's been very prominent in cancer services in the NHS in England for a long time now. So I first came across him when he was a consultant medical oncologist at Guy's and St Thomas's and a professor of palliative medicine. And then in 1999, he became the first Cancer Czar, or National Clinical Director for Cancer, I think is probably the correct title, at the Department of Health in England. And for more than a decade, I think, after that, was responsible for designing, developing, and making sure that we implemented cancer strategies in the NHS in England. He then took on another very, how can I put it, tricky job when he became the Chief Inspector for Hospitals for the Care Quality Commission, and did that role for 4 years. I'm not quite sure if he expected to be able to retire peacefully after that, but he was in 2018 asked to lead a review of adult screening programs in the NHS, which he did, and as you'd expect from what's about to happen, he reported very promptly and in a timely fashion in the autumn of last year. So I know some of you will have read that report, and I think we'll be hearing a little bit about some of what came out of that. So Mike, thank you very much. And just wanted to introduce Rebecca, because Rebecca is almost as eminent as Mike, or at least heading in that direction. But, Rebecca, as many of you will know from the Cambridge community, has become, for better or worse, imminently, very closely associated with cytosponge, which those of you who know will know all about it. So I'll say no more at the moment, but she's done much else in her professional life and is an MRC unit leader at the MRC unit here in Cambridge. She's a professor, she's an honorary consultant at Addenbrooke's, and has a bit of spare time, so she does some teaching as well. But anyway, looking forward to hearing from you both, and over to you now, Mike.
Thank you very much indeed for that introduction, John. And I will now see if I can work the technology, which is always the most difficult bit. Oh, Lord. Just give me half a second and it should come up. No, it was doing it perfectly well before. I think we're getting there. We're getting there. Can you see the slides? Is that, yeah, there's nodding going on. Phew, that's the most difficult part of the lecture over as far as I'm concerned. The rest is straightforward. Well, so thank you very much, John, for inviting me to give the lecture. Good afternoon to anybody who is listening in. What I want to do is just give you an overview of this, what I think is an extremely important subject, but you will see that as we go along. So in terms of the outline of what I'll say, I do want to sort of identify what the problem is, and then think about why does England and indeed the UK lag behind other developed countries, because I think we need to understand that if we're going to think about what can be done. There is always the question of how long will it take. I rather doubt that I'm going to answer that question, but you can all ask me, I suppose. And I'll explain why I think that one's difficult as I go along. So what is the problem? We know that both 1-year and 5-year survival has been steadily improving in this country over the last 20 years, and actually longer than that, the last 40 years. But, and there is a very big but, we now have multiple international comparisons that show that we lag behind other countries on both 1 and 5-year survival. The Eurocare study was the first high quality study to show this, and Eurocare, its first iteration was in the 1990s, but there have been subsequent ones beyond that. I got involved in the noughties, helping to set up the International Cancer Benchmarking Partnership, or ICBP, and that did some parts that were very similar to Eurocare, but it also tried to delve deeper into the question about why. And then alongside that, there is the Concord studies. The Concord studies really are worldwide, well over 100 different countries reporting, and also on quite a wide range of cancers. So that gives us a sort of global picture. And I think what all of these show is that in comparison with other developed countries, countries that we might expect to be our equals or whatever, particularly the 1-year survival is poor. If you survive to 1 year, your chances of getting to 5 years are much the same in the UK as they are elsewhere. That is really important because it's the first signal that it's about late presentation, more advanced disease. Indeed, there are studies that compare us with Norway and other countries where actually our survival in the first 3 months after diagnosis is really considerably worse. So again, that's probably not about treatment. It's much more likely to be about advanced disease. But one of the problems that we've had in these international comparisons is getting comparable data on the stage, the extent of disease at the time of diagnosis. And indeed, even in this country, we've only had reliable data on that across the country for about the last 5 years. So here's the evidence that our survival is improving. These are not my figures, they're other figures, but I published them in a report called Unfinished Business. That arose because when I retired from the Care Quality Commission, I was asked, well, what about cancer? And I said, well, that is very definitely unfinished business. What you can see, the red line is the 1-year survival. Not surprisingly, that is considerably ahead of the 5-year survival figures. Obviously, the 5-year survival figures don't go up as near to the present time because it takes time to get 5-year survival figures. And inevitably, there is a gap between 1 and 5 years because there are people who will die between 1 and 5 years. I think the most surprising thing about this graph is that it's a straight line. They're both straight lines. You know, we've done all sorts of different things. I thought I'd done all sorts of things in the noughties as National Cancer Director that might have bent that line upwards. I have to say it hasn't. I mean, it's good news that it's gone on improving, but we haven't really bent the line, and that I think is the challenge. So then let's look in comparison with other countries. And in the International Cancer Benchmarking Partnership, we chose to work with Canada, Denmark, Norway, Sweden, ourselves, and Australia. The reason for the choice of countries, as much as anything, was that they had comparable health systems in terms of they were nationwide health systems, largely paid for through taxation or the equivalent, but also they were willing to participate, and they all speak very good English. And if you want to delve down into what the reasons are rather than just the facts, that sort of ability to have those discussions is really important. So what you can see here for 6 different cancers, colon, rectum, breast, lung, ovary, and prostate, is, first of all, the good news. In all countries, over that time span between 2000 and 2014, and in all cancers, there has been improvement. That's the good news. The less good news from a UK point of view, and sometimes it's quite difficult on this slide to differentiate Denmark and the UK, but I can assure you those bottom two lines are Denmark and UK. And what you will see is, yes, we've improved, that's as I showed on the previous slide, but also we haven't closed the gap. You can argue that we might be closing the gap on some of them. Certainly breast, I think we have. We can come back to why that is, but we haven't eliminated it. Prostate is a slightly different kettle of fish, to be honest. With prostate, you will have high survival rates if you do a lot of PSA testing. I think with prostate, you really need to be measuring numbers of people dying and the numbers of people presenting with stage 4 disease, but time does not allow for that today. So that's the evidence that we're doing worse than the other countries. So now we really need to turn our attention to why do we do so badly. And I just want to highlight, first of all the different reasons that there could be, and there are a lot of different reasons. Yes, under the heading of late diagnosis, it could be because patients in this country have less awareness of cancer, or more feelings that if you get cancer, it's a fatal outcome, so why go and get treatment? Those factors could lead to late presentation. It could be that GPs are not investigating and referring soon enough, and I'll come back to that. It could be that there's poor access to diagnostics in the NHS, and probably most people in this listening to this lecture will agree with that one. I also have to say that throughout the time that I was National Cancer Director, there was the sort of ding-dong between consultants and GPs, GPs being blamed for inappropriate referrals, which may put them off making referrals. And I think that the remarkably few of those, I suspect, even when they get to hospital, do not get any tests done. So, but we can come back to that interaction. And then on the commissioner side, primary care trusts and clinical commissioning groups may attempt to ration care. I'm sure they don't mean to do that for cancer, but by having rationing, it may also impact on cancer. Now then, on the poor treatment, the main treatments for cancer are surgery, radiotherapy, and a variety of different systemic treatments, chemotherapies, immunotherapy, etc. And is it that this country has poor treatment? I think we need particularly flag the surgery one there. If there are any surgical colleagues on this call, let's remind everybody that surgery still cures more cancer than any other treatment. That sometimes gets forgotten. Of course, it's not necessarily one or other of those. It could be a combination of both of those factors, or it could be none of the above. We have to at least tackle the issue of, are the international comparisons reliable or unreliable? Is there something, are their figures inflated? Are figures abnormally bad without that meaning anything? So I probably want to tackle that last one as early as possible, because I do not believe that to be the case, nor do almost all the experts I've ever talked to. That wasn't the case 20 years ago. 20 plus years ago, actually. So in the 1990s, there was denial of a problem in the UK. And genuinely, I heard these comments, and some of these comments took the form of being in letters to the BMJ. Eurocare results can't be true. We know that the NHS is the best health service in the world. And I think that feature. Now, I'm a huge believer in the NHS. I've worked in the NHS all my life. And I'm a particular believer in the values of the NHS, the access at the point of need and free at the point of need, etc. Doesn't necessarily mean we always deliver. So that was certainly a view. And following on from that, people were saying it must be our cancer registration that was invalid. And it is true that if you go back 20 years, our cancer registration was far from perfect. And indeed, in some parts of the country, one of the measures of good registration is, do you actually pick up the patient during their life as having had cancer, or is it only from the death certificate? And we had a lot of so-called death certificate only patients. That, I have to say, has radically changed, partly because there are so many electronic feeds coming. We do pick up these patients one way or another. The fact is, we've improved our registration and it hasn't eliminated the gap. So I think we can knock that one on the head. And then the other bit, which I'll also come back to, was people saying that delays in diagnosis of only a few months, they really can't make a difference to outcomes. I'm afraid we may get the final proof of that this year with the pandemic, and we can pick this up later on. But what we are seeing with the pandemic is some patients probably not ever getting to hospital. I've heard reports of people with acute leukemia, for example, just not the numbers not coming through. So were they dying? Were they being recorded as dying from COVID? I don't know. But I'm also hearing a lot that patients are presenting with more advanced disease than normal. So I'm afraid this may give us the final evidence, although I wish it hadn't taken the pandemic. So why does my own interest fit into that 1990s picture? And it really stemmed from my work as a clinician. And John has already mentioned that I was an oncologist, particularly specializing in breast cancer at Guy's Hospital. And I remember distinctly one Friday afternoon in 1991 being asked about advice on an individual patient at another hospital, in fact, in Canterbury in Kent, as to whether a 32-year-old with breast cancer should get adjuvant chemotherapy. And so I asked some basic questions. Has the cancer spread to the axillary lymph nodes? The surgeons in Canterbury don't remove lymph nodes, I was told. What grade of cancer was it under the microscope? The pathologists don't grade cancer. How large was it? Unfortunately, that wasn't recorded in this case. Now, I realized that at Guy's, I had that information on every single patient I saw. My job was a doddle. But I then decided I better find out if this was localized to Canterbury. I did a large study with the Thames Cancer Registry covering Southeast England at the time. And there was huge variation in what was going on, both in the diagnostic process and in treatments for breast cancer, even in a group of women under the age of 50, where there was the best evidence about what we should be doing. Equally, as a clinician, I was seeing a lot of patients with breast cancer, some of whom presented with tiny breast cancers, less than the size of a pea, and had only just appeared. Others came with a lump that had been there for months and years and might be measuring 10 or 12 centimeters by the time it was diagnosed. And that set me off on a program of research with a colleague, Professor Amanda Ramirez. Why do some people present early and some people present late? In parallel with that research, I was doing research to try and find out whether it actually did make a difference to outcomes. And fortunately at Guy's, we had data on how long people had had symptoms. For some reason, this had always been asked and recorded on a database for every patient with breast cancer, but nobody had ever looked at it. This was probably one of the easiest papers I've ever written. And lo and behold, people that had longer symptoms for longer did do worse. And that was even true when you took diagnosis from the date they said they'd first noticed symptoms. So I think it was fairly robust. Anyway, nobody believed it. They just said, that's Guy's, we can't believe that, that's patient report. So I thought, well, maybe I ought to look at what the whole literature says on this. And I applied to the Department of Health for funding to do a systematic review. And I got 2 negative peer review reports from that. One of which said, there's absolutely no point in doing this systematic review. It's so obvious that delays will make a difference to survival. And the other peer review said exactly the opposite. There's no point in doing this research. There's no way that delays of a few months could make any difference. So anyway, I took that back to the Department of Health and they then did give me the funding. My pride about this the study is, I think it's the only systematic review that goes back to 1906. If anybody's got a longer one than that, do please tell me, but I'll be very sad. Roughly speaking, there have been 1 paper a year on this subject, and taken together, the evidence was overwhelming, except for one study published in 1950 by Bloom et al., where it said the opposite. And it's amazing how many of my clinical colleagues were quoting the Blue et al. Study. Anyway, as the 1990s moved on, the general feeling that we needed to do something more about cancer grew. And that was partly because of the evidence of poor survival, partly because of patient pressure, and partly because of the so-called postcode lottery of people having unequal access to treatments. So alongside the Downing Street Summit, Tony Blair made cancer a top priority, not the top priority, because he then added a couple more top priorities. And shortly after that, I was asked if I would be National Cancer Director. I then met with Tony Blair just into 2000, and he asked me 5 questions. Is cancer as bad in this country as bad as people make out? Why? What are you going to do about it? How long will it take, and what will it cost? I think I got the first 3 questions right, and I certainly got the last 2 questions wrong, but fortunately he did out of that say, go ahead and develop a cancer plan. And I can tell you, developing a cancer plan is a whole lot easier than trying to implement it. And anybody else who's developed strategies, I'm sure will know that. So going back to why do we do so badly, and this is the deep dives that we did through the International Cancer Benchmarking Project. First of all, as I've already shown on the earlier slide, we did confirm that survival was poor compared with other countries. We did this study looking in depth at what the public, not patients, but the public thought about cancer, their awareness and beliefs. They were broadly very similar to those in the other countries we were studying, except for one question. And people in this country were uniquely concerned about bothering their GP. When we reported that to the rest of the international participants, they just raised their eyebrows and said, what? How can that be? And then we did another study, which was giving GPs in all the countries scenarios and saying, what would you do with a 60-year-old woman who had a cough and this, that, and the other? What would your next step be? And again, British GPs were much less likely to either investigate those patients or refer them than their colleagues in other countries. So those, again, I think gave us quite a lot of clues. Next question, is it our cancer screening services? I'm going to say an outright no to that because they broadly compare well with those in other countries. I know they could do better. I wrote a report on that last year, and in practice, the main thing we could do is to increase uptake, and there is an evidence base on what we can do there. And anyway, screening really only applies to breast, bowel, and cervical cancer, and we do badly on lots of other cancers, so it can't just be screening that is the problem. Indeed, I've already shown that we're narrowing the survival gap for breast cancers, and that could be partly due to screening. I think we've got our breast screening service does compare well with other countries. The other thing is we have worked very hard to introduce one-stop shops, so anybody with a breast symptom can be seen within 2 weeks and in a one-stop shop. Next question about why we do so badly. Is it our diagnostic services? And most of this year, I've actually been writing a report for NHS England on diagnostics. Diagnostics across the board, that's imaging, endoscopy, pathology, so-called physiological measurements, not just cancer. And what that's shown is that the demand for diagnostics has been growing faster than capacity. We don't have enough equipment, I will show that in a second, and nor do we have the workforce to go with it. And so even before the pandemic came along, we were reaching a tipping point where particularly waiting times were getting worse. And because of that, we were having to outsource more work, both in terms of getting CT scans done, but also in terms of reporting them. But that applied to endoscopy and pathology as well. I'll show you the figures for CT scanning and MRI scanning capacity in a moment, but along with that went to the workforce numbers. And I genuinely believe that our diagnostic services have been a Cinderella in the NHS, and some diagnostic services within that are Cinderellas of all Cinderellas. It's interesting. Everybody says it's important, but then nobody has really pushed to try and sort that out, I hope, until now. So this is the evidence about CT scanners, the number of CT scanners per 10,000 population. These are OECD figures, they're not mine. And you will see in green on the bottom left is England. Pretty, against, you can read the countries that are there, but France and Spain have roughly double the number of CT scanners per head of population. Denmark, which has really made a big push on its diagnostics in response to what they learnt out of ICBP, has now got 4 times as many as England, and Italy is at 3 times. So we are bottom of that league table, and I'm afraid it's not much different when we come to look at MRI scanners. The green of England, yes, we are ahead of Hungary and interestingly ahead of Israel, but compared with France, which again has, roughly speaking, twice the number towards the right of the screen, and Italy, I think, is about 3 times our number. So it's, you can look at the picture for yourselves. We are woefully poor in terms of scans, and with that, the workforce needed both to do the imaging and to report. The reason I show scanners is we've got international data there. We don't have international data, up-to-date international data on colonoscopy. We did have some about 10 years ago, and I can assure you England was worse than Poland, and Poland was far worse than Australia or Canada. So that's the position there. And then we come along to what happened with COVID. These slides are relatively up to date, but only actually up to July, but they show what the initial impact was of the pandemic on diagnostics. Maybe if I start at the right-hand end with colonoscopy and beneath that gastroscopy, you can see the plummet downwards. Both of those were deemed to be aerosol generating procedures and therefore potentially high risk for the operator. And they've been very slow to climb back up. I must say that since this picture, there's been a huge amount of work, and they are coming up really quite quickly now. The CT scanning at the left-hand end was less affected, and again is just about now up to what it was before. We would expect it to have been at least 7 to 10% higher because we're a year further on than the figures for 2019. So you can see a massive effect of the pandemic. One of the things this has done is actually to focus the NHS on diagnostics in a way that a report just from me could not have done. Everybody is now clamoring for better diagnostics, which again, it is sad that it's taken a pandemic to do that. So what can be done? Well, can we encourage patients to present earlier? Yes, of course, we can have public awareness campaigns, we can have local campaigns, national campaigns. It is easier said than done. We've done some awareness campaigns. If I'm honest, I think they've only had limited success. And I wish we'd done better, and maybe we can think of better ways of doing that in the future, but they have had some impact. I think the greatest thing is being able to say to patients, the GP's door is open. And that's been particularly difficult during the height of the pandemic. Then once they've got to the GP stage, we can encourage GPs to lower their thresholds. There is a gatekeeper mindset, and I'm not again blaming GPs for that. I think we've asked them to be gatekeepers over a period of 70 years, and they've become gatekeepers, and they've partly become gatekeepers because of the next stage down the line, the diagnostics. I think the NICE guidelines that have been developed on this for urgent referrals have been helpful, and that's pushing things along, but we've still got a long way to go. And then you won't be surprised in view of what I've said before, that I think we need to improve diagnostic services, but we do need funding for that. And anybody listening to this call who's got access to Rishi Sunak in the next week, please tell him that it needs to be in the comprehensive spending review, because time is getting very tight. So we need the money for more equipment and facilities, but we also need to do things differently. And one of the things my report suggests is that acute and elective diagnostics can be separated and become, both streams then become more efficient. I can talk more about that later if people want. And of course, we need the workforce, but we also need to drive skill mix initiatives. They've been done successfully for some parts of the diagnostic service, but not for others. Then what else can we do? We are already improving the bowel screening program. The change from so-called FOBT to a fecal immunochemical test, or FIT, has been a great success. It's a simple reason. FIT is you just have to have one stool sample. FOBT required 3, and it's about a 10% increase, or best part of 10% increase in the uptake. But at the moment, our program only runs from age 60 to 74. We want to reduce the starting age to 50. All the evidence is there that this will improve the outcomes. That's outcomes both in the number of cancers are picked up early, and also in picking up the polyps that could become cancers, thereby preventing cancers. We also need to lower the threshold. The threshold is artificially set at 120 micrograms per gram at the moment. At the very least, we want to reduce that to 80. Both of these things, the thing that's holding it up is that we need to train more screening colonoscopists, or develop different approaches. And then that comes on to other things that can be done. The same FIT test can be used to triage symptomatic patients, and that's just beginning to come in. John mentioned the cyto sponge. I'm not going to say much more about that because we've got the world expert on that, who's going to respond to my talk, Rebecca. But I think that does have great promise for diagnosing upper GI cancers. For lung cancer, we are implementing lung health checks, which could lead on to a national screening program for people who have been smokers or ex-smokers. And again, there is international evidence that that would save lives. And then there are lots of other new technologies that are not yet fully tested. The term liquid biopsy has come in, which I find fascinating because I think it's largely means a blood test, but it's so much sexier to call it a liquid biopsy. But basically, these blood tests can pick up circulating tumor DNA potentially before any other signs of cancer are available. And there is at least one that we hope to get fully trialed in the UK very soon. So I think there's a lot that can be done. And just in summary, I hope I've proved to you that we still have poor cancer survival in this country, so it needs to be a priority. All the evidence is that if we could match other countries, I didn't show this, but I should have done, we could save between 5,000 and 10,000 lives a year. So it is not a small matter. Late diagnosis, I hope I've convinced you, is a major player in this, but that there are lots of different factors between underlying the late diagnosis, patient factors, GP factors, NHS service factors. I do not believe we can claim to have a first-class health service until we've tackled this, and with that, put in place the structure that we will need when new tests, cytosponge or others come along. We've got to have the health service ready then to deploy those. And the NHS long-term plan has made a commitment that we should diagnose 75% of cancers at stage 1 or 2. That's great. We're only at 55% now. It's a very, very challenging target to get there by 2028. So I'm going to end there and say thank you very much for listening and handing it over at this point. Thank you.